Thank you, Dr. Chung, and thank you for having me here too. Again, so so my name is Priya. I'm one of the renal faculty, and pleasure being here this afternoon. So we'll be talking about the renal effects of chemotherapeutic agents. So just a little bit of background: the prevalence of chronic kidney disease in cancer patients has been studied by a series of trials called the IRMA studies. And they looked at around 5,000 patients with only solid tumors, and roughly half of these patients had reduced GFR. And in their population, the breast cancer had the highest prevalence of CKD. In another series, they reported that there is about an 87% prevalence of CKD in patients with renal cancer. So cancer is very predominant in our chronic kidney population. The IRMA-2 study assessed the impact of renal insufficiency with a 2-year follow-up and showed that patients with GFR less than 60 had a lower survival compared to patients with GFR over 60. And the other studies also highlighted the importance of proper dose adjustment of chemotherapeutic agents in CKD. So the cause of CKD and AKI in our cancer patients, you guys seen a lot of these cases. Usually, to name a couple of these causes include drugs such as traditional chemotherapies, novel targeted therapies, immunotherapy, bisphosphonates. Cancer-mediated causes of AKI and CKD include paraneoplastic syndrome, tumor infiltration, obstruction, and RP fibrosis. And these patients also have the typical causes of AKI, including prerenal azotemia, ATN, AIN. So we'll mainly talk about the drugs today. So the risk of nephrotoxicity from chemotherapeutic agents depends on factors that are specific to the patient, drug, and the kidney. Per those studies that I just mentioned, 80% of those patients received potentially nephrotoxic agents. And since the kidneys receive 25% of the cardiac output, they're inherently vulnerable to injury. The renal tubular epithelial cells, particularly the loop of Henle, are at a higher risk. And that's because these cells have organic cationic transporters and organic anionic transporters that facilitate the drug entry into the cells. So the higher risk of nephrotoxicity happens in females, older females, and these populations have lower muscle mass. So when we see lower levels of creatinine, we may interpret these levels as being normal kidney function when their kidney functions may not exactly be normal. And we should probably be using measures like creatinine clearance or maybe even C to look at other better ways of estimating GFR in these patients. And we just need further studies on these topics.
Do we have C levels?
Yes, we do. Yeah. Other comorbidities include liver disease and CHF. And these patients develop toxicity because of dysfunctional renal state. Chemo also has adverse effects such as nausea, vomiting, creating a pre-renal state. And there are certain types of cancers that have a higher incidence of renal disease, such as biliary obstruction causing AKI, lymphomas and leukemias causing TLS, and paraproteinemias causing CAS nephropathy and amyloid. So we'll start with the conventional chemotherapies. Here's a huge list of all the therapies that we're not going to talk about today. I'm only going to highlight a couple of these agents. I don't want to scare people. So again, how does chemotherapy actually affect the kidney? Most chemo agents cause intrinsic renal disease at different parts of the nephron. However, you can see prerenal azotemia and postrenal AKI. Prerenal azotemia can happen from a capillary leak syndrome, and that's particularly IL-2 driven. In postrenal AKI, that's pretty rare directly from chemo, but in patients who get cyclophosphamide, they can develop hemorrhagic cystitis causing vesicular thrombi and bladder outlet. Just a quick review of the definition of AKI, KDIGO definition of AKI. It's divided into stage 1 through 3. Stage 3 is the most severe. We're looking at both the creatinine change as well as the urine output. So pretty much severe AKI, we're pretty much looking at stages 2 and 3. These patients have at least a doubling of their serum creatinine and start becoming oliguric. So, why does it even matter to you guys and us? Ultimately, even though we don't prescribe chemotherapy, it's important for us to identify these potentially life-threatening complications of these agents. And as you see, a lot of chemo agents exert their effects for several months to years, even after their last dose. So these patients might not be admitted to oncology for hypomagnesemia from cisplatin, but they're going to come to medicine. So where in the kidney do the chemotherapeutic agents exert their effects? They can be tubular, glomerular, or electrolyte disturbances. The tubular disturbances include ATN, AIN, proximal tubulopathy. The glomerular disturbances include TMA, and some agents can cause FSGS. And electrolyte disturbances include hypomagnesemia and hyponatremia. So we're going to mainly focus on the intrinsic causes. It's just a list of, I just did the medications we're going to be talking about. All right, so first we're going to talk about the platinum-based compounds, and they typically, their effects in the proximal tubule over here, and we'll talk about cisplatin. A lot of the platinum-based compounds are implicated in ATN, and as you know, these patients tend to have high urine sodium with a phenol of more than 2%, and when we examine the urine microscopy, we see muddy brown casts. And depending on the severity, these patients may develop long-term CKD, and if they develop oligonuria, they need renal replacement therapy. So we'll start off with the case. You're a 66-year-old man with hypertension, CKD stage 3, with a baseline creatinine of 1.5. He has newly diagnosed non-small cell lung cancer and has started on chemo with cisplatin. The creatinine goes from 1.5 to 3.7, and of note, this patient is hypokalemic and hypomagnesemia. The urine analysis is negative for proteinuria and glyceria. The microscopy shows muddy brown cast. This is pretty typical of cisplatin-induced toxicity. Cisplatin is used for many sarcomas, carcinomas, and the cisplatin is actually taken up by the proximal tubule and through a reactive oxygen species that causes kidney injury and apoptosis, resulting in ATN and proximal tubulopathy. Cisplatin can also cause derangements in magnesium metabolism because of direct injury to the ascending loop of Henle cells. Again, these patients have progressive azotemia with a blood urinalysis. Hypomagnesemia is reported up to 6 years after cisplatin therapy, and depending on the dose, between like 40 to 100% of these patients get hypomagnesemia. And also, aside from hypomagnesemia, patients can become hyponatremic as well due to renal wasting. So ultimately, they don't exactly know the mechanism, but because of there's injury, like in the distal loop of Henle and the distal tubules, patients can become hypomagnesemia. This is just a schematic of the proximal tubular cell uptake of cisplatin from just the blood compartment. This is the urinary compartment, and ultimately cisplatin is taken up from the blood and pretty much activates this apoptotic pathway, causing cell injury. So the management of induced nephrotoxicity is centered on prevention and using other platinum therapies like carboplatin and oxaliplatin in high-risk patients. Also, these patients may benefit from volume repletion and forced diuresis with isotonic saline. There are a few newer interventions, but they haven't really been studied yet. There's a drug called amifostine, which is a glutathione analog that blunts cisplatin-induced toxicity, but it has severe nausea and vomiting, so that's why it hasn't really been used. And there's some data supporting magnesium repletion to help attenuate cisplatin-induced toxicity, but we need more studies on that. The next drug that we'll talk about is another agent that affects the proximal tubule called Ifosfamide. So Ifosfamide is an alkylating agent that's used in solid tumors, particularly testicular cancer, sarcomas, lymphomas, and it causes the proximal tubulopathy. It's a cousin of cyclophosphamide, but cyclophosphamide isn't metabolized into a nephrotoxic agent. So pretty much isophosphamide is metabolized into this chloroacetylaldehyde, which is nephrotoxic and can cause a Fanconi syndrome. So just to review, Fanconi syndrome is a proximal tubular dysfunction with with hypoglycemia, renal phosphate wasting, and potassium wasting, proximal RTA, hyperuric cystinuria, and amino aciduria. So unfortunately, a lot is not, again, with like a lot of these conventional agents, how to prevent toxicity isn't known. These patients unfortunately develop like chronic kidney disease and tubular dysfunctions that can last for years. The last conventional agent we'll talk about is methotrexate. It's an anti-folic acid agent that's used to treat a variety of high-grade lymphomas. The high-dose methotrexate has a potential for nephrotoxicity because it causes precipitation of the drug and directly affects the renal tubules. And patients typically develop a non-oliguric AKI with a bland urinalysis. And medications like probenecid, penicillins, and NSAIDs also compound the risk of AKI in these patients. So this is a light microscopy image of the renal tubules with methotrexate precipitated in them, pretty much causing tubular obstruction. In order to prevent nephrotoxicity, we recommend volume repletion before and after drug dosing, urinary alkalinization, and obviously appropriate dosing for renal function. The treatment of methotrexate nephrotoxicity is comprised of glucocorticoid rescue. And there's another agent called glucarpidase, which is a recombinant bacterial enzyme that rapidly reduces methotrexate levels. And I think because of its cost, it hasn't really been used in clinical practice yet, but it ultimately metabolizes methotrexate in like 15 minutes. So you can really reverse toxicity. And in patients who require dialysis, dialysis has good clearance of methotrexate, but there's a rebound effect. So now we're going to move to glomerulus, and we'll talk about thrombotic microangiopathy with medications like gemcitabine and the antiangiogenesis agents. So chemotherapeutic agents such as gemcitabine and the VEGF pathway antagonists can injure the renal vascular causing TMA, and that's the most life-threatening complication. And these patients present with hemolytic anemia, thrombocytic leukemia, hypertension, and AKI with an active urinary sediment. Gemcitabine is a cell-specific pyrimidine antagonist that's used for lung carcinomas, pancreas carcinomas, and there have been a lot of case reports of gemcitabine-induced TMA. Sometimes it happens up 7.5 months after their initial treatment, so it can be long. It can take a while to manifest this. And unfortunately, for these patients, most of them undergo conservative therapy, but there have been some case reports of possibly using eculizumab in these patients. So the next category of medications we'll talk about are the anti-angiogenesis medications. And so the angiogenesis is important for tumor growth and development of metastases. VEGF is a pro-angiogenic factor that binds to a family of VEGF receptors. And VEGF is really important in the kidney to actually maintain podocyte health. VEGF also blood pressure by upregulating nitric oxide production and increasing prostacyclin production, causing vasodilation. And there are several classes of VEGF pathway agents are available. We'll specifically talk about bevacizumab. These patients, these patients can develop TMA with the same kind of findings as gemcitabine with hypertension and proteinuria. But a lot of these patients actually end up just developing hypertension. And we use hypertension as a gauge to respond to the drug, but still as clinicians we should be treating the hypertension. So this is just a schematic of the VEGF receptors in the podocyte. This is the podocyte here, and this is the endothelial cell here. So just highlights how VEGF is important in the kidney. And again, like the manifestations of VEGF inhibition include hypertension, proteinuria, TMA, and there are even electrolyte abnormalities with medications like cetuximab, for example, causing hypomagnesemia. Here's a list of different classes of the VEGF, the drugs that target the VEGF pathway. And then we'll have a case, which is a 71-year-old woman with hypertension, recurrent ovarian cancer, started on bevacizumab. She had had well-controlled hypertension on only 5 milligrams of amlodipine. And since starting the chemo, her doctor had to add lisinopril 40, hydrochlorothiazide 25, and she was maintained on the amlodipine because she wasn't able to tolerate a higher dose. Her blood pressure has still been rising, however, it's ranging between like 110s, 160s, and these blood pressure spikes happen randomly, so we couldn't just change timing of medications to help with her blood pressure. So this is an audience response. What would you do next? Would you discontinue bevacizumab, add isotorbide dinitrate TID, add losartan, or switch to nifedipine from amlodipine? So takers for A, B, C, D. Okay, so we have 2 takers for D. Ultimately, to treat hypertension from medications like bevacizumab, ACEs and ARBs are the first-line agents. They treat both the hypertension and the proteinuria. This lady was already on lisinopril, and her goal blood pressure is less than 140/90. In this patient, however, since she had like some normal blood pressures and some really high blood pressures, we didn't want to put her on any long-lasting agents because she may experience lows. So that's why we didn't put her on losartan, or we didn't switch her from amlodipine to nifedipine. Interestingly, the VEGF inhibitors are associated with a decreased serum and urine nitric oxide, and by adding nitric oxide donors, we can actually improve the blood pressure by 30 to 40 millimeters of mercury. So in her case, we added isotorbide dinitrate, and her blood pressure was better. So then the same patient comes in with blood pressure in the 70s. So now what happened? A, did she have an occult infection? B, did she stop bevacizumab? Or C, did she develop TMA? Any takers for A? B? C? No takers for A. So in this case, discontinuing medications like bevacizumab, the hypertensive effect can wear off after several days to weeks. So these patients can actually develop hypotension because they're on all these other medications to help with their blood pressure, and then all of a sudden their oncologist decides to stop this medication, and then they come into the ER with a blood pressure of 70s and acute kidney injury. So it's the patients do need education about at least having their internist, their oncologist, nephrologist all working together to make sure that these patients don't have hypotensive episodes after coming off of these medications. So the last category that we'll talk about is checkpoint inhibitors, and pretty much the cancer cells within the tumor microenvironment resist and evade the host immune system by expressing these inhibitory ligands to suppress T cell activation. So ultimately, the goal of the checkpoint inhibitors is to allow the host immune cells to identify and eliminate these malignant cells. However, that pretty much leads to the checkpoint inhibitors pretty much leads to unrestrained T cell activation, and that has complications. And we're seeing these drugs more and more. They're practically involved in a lot of the cancers that we're seeing nowadays, and causing a lot of the side effects. As you can see, pretty much you can have side effects all over the body. You can have neurologic side effects, endocrine toxicities, pulmonary toxicities, skin issues, obviously renal toxicities. So it pretty much has a whole organism-wide effect. So the most predominant renal lesion from checkpoint inhibitors is acute interstitial nephritis, and there are several case studies that have been done, and the acute kidney injury from allergic interstitial nephritis can happen between like 1 to 24 months after exposure. However, ATN has been seen on biopsy too. And unfortunately, even though we think we can guess based on urine microscopy, the person has ATN versus AIN, there's really no good laboratory data to really figure this out. And this really pretty much highlights the need of a biopsy. Unfortunately, sometimes these patients develop AKI. The oncologists think it's AIN. They load the patient with steroids and they stop the drugs that could potentially be helpful for the patient. But this patient actually has ATN, which ultimately is time for waiting. So I think especially the severe cases of AKI, going back to the KDIGO classification, classes 2 and 3, stages 2 and 3, would probably benefit from biopsy. And if these patients do have biopsy-proven AIN, depending on severity, we recommend their pulse steroids followed by oral steroids or just oral steroids for less severe AKI. Also, there's more and more data about glomerular nephropathies coming out with checkpoint inhibitors too. There's just recently studies on recently reports on ANCA vasculitis, IgA nephropathy that we're seeing with these checkpoint inhibitors. So I think we just need to, I think it's a matter of time for us to kind of see all these renal manifestations. The most common electrolyte abnormality, Dr. Kochar, I think, and I have a patient on her service, is hyponatremia. So this patient, I saw him in renal clinic. He's a 67-year-old guy with bladder cancer, with muscle invasive high-grade papillary urothelial cancer. He was started on gemcitabine, cisplatin, and nivolumab, which is the checkpoint inhibitor. So his last dose of nivolumab was in May, and then he was hospitalized in August at another hospital with a sodium of 105, was thought to be SIADH. They allowed his sodium to raise appropriately. They discharged him on salt tabs. Sodium on discharge was 129, and then he saw me a couple of weeks later in renal clinic, and he was hypertensive to 80 with a sodium of 124. So any takers on his cause of hyponatremia? A is SIADH, renal insufficiency. C is hypophysitis. D is hypovolemia and appropriate ADH response. E is all the above. Anybody for A? B? C? D? E? E. It's a trick question. It was all the above, So, ultimately, this guy was found to have a very, very low random cortisol level, less than 1. And he was ultimately thought to have adrenal insufficiency from the nivolumab. His pituitary function was intact. I think endocrine was on board. He was started on hydrocortisone, and now his sodium is 134. So, ultimately, the patients with cancer and hyponatremia, they have to get a full workup. A lot of things can cause hyponatremia in these patients, and now we have to keep checkpoint inhibitors in mind as well. And they can cause again, hypophysitis, isolated ACTH deficiency, adrenalitis, thyroiditis. These patients need a thorough evaluation of their pituitary hormones, pituitary function, as well as an so in summary, many conventional chemo agents cause a variety of renal effects, such as electrolyte disorders, glomerular lesions, TMA. A lot of these drugs are excreted by the kidney and need dose adjustment. Hypertension from the VEGF and TKI agents should be treated with a combination of long and short-acting agents that can be modified if therapy is discontinued. And for checkpoint inhibitors, the most common renal finding is allergic nephritis, and the electrolyte finding is hyponatremia. Can I answer any questions? Yeah, so I think you can probably see it in this patient, he didn't manifest hyponatremia for 3 months. His last dose was in May, and then he was admitted in August for hyponatremia. So even after, there's a pretty huge delay with when you can actually manifest. Is there anything else? Yes. So a lot of the kidney, what I think for a lot of the patients, AKI, a lot of them end up developing long-standing CKD. They may require dialysis, and then when they have kidney injury, a lot of them do come off dialysis if they need it. But ultimately, the chronic kidney disease lingers, and even the electrolyte abnormalities can linger.
What's the rate of being renal failure?
I think it's so. Per the biopsy, it's actually very rare to actually develop AI to allergic interstitial from or ATN from checkpoint inhibitors. It's rare. I don't exactly know what the rate is. I can like give you a number, but I think like overall, when I was looking at the case series, I think it was less than like 5%. I think less than that even. So I think it's rare, but yeah.
And then once it's more permanent.
So once you develop any form of kidney injury, you are at a higher risk of developing chronic kidney disease. In terms of like, I don't think any of the I have to look at the reports again, but I think most of the patients that even got a course of steroids, I don't think the kidney function went back down to baseline. Maybe the ATN patients probably have a higher chance of returning back to their baseline, but the AIN patients, because even steroids aren't like the best treatment. I mean, like that's the best that we have at this point, but like sometimes it doesn't really change the course as much as we would like.
Are there any data for if like a patient on a patient checkpoint inhibitor
Yeah.
has possible influences AIN for which one? Are there any data to see like the earlier you initiate steroid therapy, the better it would be, or
So in terms of like, I think ultimately if we're not sure, we should just go to biopsy first. And as long as these patients are at a lower risk of biopsy, their blood pressure is controlled, then I think it's a percutaneous biopsy is probably the best way. And then at that point, like biopsy proven AIN, we do recommend giving a course of steroids. But I think especially these patients who, if there's something that's, I mean, I think ultimately if their acute kidney injury is severe, if it's more than like stage 2, stage 3, I would recommend just checking it, making sure, yeah. At least then we can prognosticate, we can let the patient know what to expect. So I think we should be more aggressive in the biopsy, personally.
thank you.
Thank you.